Now, of course, there were no blood tests, ECGs, imaging, or clinical findings because none of these people sought medical attention before they suddenly died. In one patient, a witness described a rattling breath shortly before discovering an absent pulse. In another person, they complained about nausea and were found dead soon thereafter. Resuscitation in that case was not successful. The other 3 people were simply found dead at home without any information about terminal symptoms. According to the available information, none of the deceased had previous COVID infection, and swabs taken for the COVID virus were negative at autopsy in these people. 4 people died after the first vaccination, and the remaining case was after the second one. There were 3 females and 5 males in this autopsy study. The average age was 58, with a range of 46 to 75 years of age, which is certainly older than what I've been talking about in the above studies. As on this slide, you can see the 5 cases, and in these 5 people, it's important to note that they found no other cause of death. The cardiac pathologist felt that 4 out of the 5 cases were definitive for myocarditis according to our standard Dallas myocarditis criteria. They felt that 3 out of the 5 were likely related to the vaccine, with 2 out of 5 being possibly related. The pathologists described their findings in the study, and in all 5 cases, the microscopic findings were the same. They did say that during the last 20 years of their autopsy service at the University Hospital in Heidelberg, that they did not observe comparable microscopic cardiac muscle inflammation or infiltration like these. This autopsy information in 5 patients allows physicians and, of course, pathologists to better understand situations where we may have a patient in the hospital that we choose to biopsy. This way, findings can be interpreted and correlated with what they found in this study. They summarize by saying that in these 5 patients, no other cause of death except myocarditis was identified, and hence myocarditis has to be considered the likely mechanism of death. They felt that the myocardial damage they were seeing in the cases were not sufficient to suggest that poor heart function was the terminal cause of death. And so most likely an abnormal heart rhythm, either a cardiac arrest with no electrical impulse or another life-threatening rhythm, had to be assumed as the mechanism, the immediate mechanism leading to the patient's death ultimately. Now, myocarditis-related acute cardiac arrest due to life-threatening rhythm disorders is a well-established mechanism in other cases or causes of acute myocarditis. Their summary is a very small number of patients, just 5, and it's obviously descriptive or observational. It gives no idea about the frequency of myocarditis from vaccination, and obviously, ultimately, it does not provide a direct causal link from vaccination to myocarditis, and I can't emphasize that enough. They finish by stating that considering that this adverse event, which is fatal, may affect healthy individuals such as registry and surveillance programs, they may improve early diagnosis, close monitoring, and treatment. If these deaths at home were secondary to vaccination, we of course may be missing some severe myocarditis cases in our studies. Not every death at home will have an autopsy. Now, please note that this video is clearly not anti-vaccination. It's reviewing research into myocarditis, and vaccination has been helpful for people, particularly at high risk of a severe outcome, to prevent hospitalization and death. But with any intervention, it's important that we as physicians select the right people for the intervention, balancing the risks and benefits. And the risks, of course, need to be known. Certainly risks that are serious, even if very uncommon, need to be elucidated and understood. This allows physicians to have good risk-benefit discussion with patients so that patients can make an informed decision. As we go down the road and people receive more vaccines, more boosters, whether it be annually or what is recommended for people at high risk, we need to understand the benefit in that group as well as the risk. We also need to know what it is for different patient populations, because obviously the risk is going to be different if somebody's young and healthy versus older, as well as whether these people in question that you're talking to, whether they've recently had infection or how many infections that they have that might deliver some immunity to them each time they get reinfected. These are the sorts of things that we try to balance when we're making decisions on health care for people. Thanks for joining me today on Medicine with Dr. Moran. Get healthy and stay healthy.